services for our patients and referrals, enhance oral diagnostic education of our students and healthcare providers. And so this presentation really supports all of us here at Western. A brief introduction about Dr. Nicholson. So he received his BA at the City University of New York, Brooklyn College, then his MD at Case Western in Cleveland, residencies in internal medicine, anesthesiology in the Hospital of Cleveland. He maintains triple board certifications in internal medicine, critical care, and sleep medicine. We were just talking about that, quite a feat. And his interest in sleep medicine prompted him to assist and develop the Sleep Disorders Center at Pomona Valley Hospital and Medical Center in 1987. Welcome. Thank you so much for being here. We look forward to your presentation.
Thank you. Happy New Year to everyone. Thank you for giving me the opportunity to talk with you. I'm excited about it because there's a strong role of the dental community to play in treatment and diagnosis of sleep apnea. What I'm going to do today is review a general concepts of sleep apnea and some of the diagnostic and treatment tools. And I have a lot of slides, and so there are handouts for those who want to torture themselves afterward, but I may skip over in order to cover the whole topic. So if I'll reserve questions if there's time at the end. The disease I'm going to talk about, I have come to feel, for those of you who are old enough to remember, is the Rodney Dangerfield disease. And I say that because it's a disease with tremendous implications for health that gets very little respect. And, you know, when I first started out, everyone laughed when someone snored, or they said they snored. So let's go into this and sort of look at really what happens to people who have sleep apnea and the incidence. So first thing I'd like to talk about is what is it? And let me parenthetically say that that's still an open question, that people understand that there are repetitive obstructions in the airway that result in weight arousal, other physiologic consequences, and low oxygen in the blood. I think most people agree with that. The problem with this disorder is it's common, very common, sometimes as much as 50% of certain populations, and it's treatable, but it's poorly identified, so that only about 15% of people who actually have sleep apnea are actually identified. I don't know if you can see it, I guess it's blocked up there. So the incidence or prevalence, not incidence, of the disease is much higher than people might realize, and it occurs up to 20%. Depends on the definition. So if I said, you know, middle-aged people, 35% of people have, as many as 35, and then there's criteria of how bad it is that affects these numbers. But in essence, a lot of people have this disease, and most don't know it. So what are the symptoms? Excessive sleepiness, snoring, holding your breath during sleep, choking, gasping in sleep, and interestingly, nocturia, which is frequent urination during sleep. So you're awakened more than you should be. In fact, I have lots of patients who come to me after have been seen by the urologist, having had 3 to 5 times a night, but they have to get up, and they're often men, and so they you know, think they have a prostate problem. After treatment, that gets better. So who gets this? These generally are, if you wanted, the largest category, the 40 to 60-year-old people, but it can happen at any age. And obesity plays a definite role. So the heavier you are, the more chance you'll have this breathing obstruction during your sleep. But don't be misled. You can have thin people. I had a patient who was a woman with fitness person who did wrestling and other fitness, and she was skinny, thin at least, and muscular, and she had it for reasons related to other medical issues, which I'll touch on briefly. Some medications do that and cause the sleep apnea. They're mostly sedative, hypnotics, and narcotics. And you see an awful lot of people on those drugs. So alcohol will definitely do that. And you know, the alcohol is a muscle relaxant. So when people go to sleep and they have a drink before they go to sleep, the severity of sleep apnea increases. And of course, smoking, and there's a family, but not a genetic history. Definitely runs in families. Okay, now don't forget children. And we see a lot of kids who have this disorder. And those kids are in different situations. A lot of them have tonsil enlargement. Some of them have craniofacial congenital abnormalities, and they present to various people, including dentists, with those kind of things to be fixed, but often the question of how is their breathing doesn't come up. This particular child, you can see a retraction of the sternum during sleep because the chest is moving in when it should move out. So, you know, it causes a serious problem, flaring of the ribs and so on. I mention all these syndromes just because I don't usually deal with them, but they're out there, and they're a small percentage of kids. Most kids who are seen have tonsil and adenoid enlargement. I just picked up something today, and they said they finally decided to say that kids who have tonsillectomies for this condition do better, but it's been in the literature for 30 years. So here's an example of a kid and an adult who have this facial abnormality related to a particular syndrome. And just the point is mainly there are lots of people who have dysostosis or retrognathia or other issues who are not fat. So you can't look for obese people. You have to look at the person and see what the issue is. People who have low thyroid, there's some rare diseases that are associated, but it's mostly facial construction, motor abnormalities, and obesity that, you know, have an impact on this. So I mentioned some of the symptoms. One of them is having a very angry spouse who is not happy about it. Let's quickly look. I'm not going to spend a lot of time on this, but the physiology is interesting. And it's still not fully understood. But basically, no one snores when they're awake. So if you start out with that premise, then it can't be all anatomy, right? Because otherwise everybody would be snoring who had this during the day when they're awake. So it's a combination of physical, of musculoskeletal abnormality and muscle relaxation that occurs when people go to sleep. There's a discoordinate muscle activity which leads to a collapse of the airway. I put this on here not to go over each little thing, but to give you some general sense that they're all connected. So what happens is then, if it's real bad, you can get cardiac irregularities, hypertension, low blood pressure even can occur. And importantly, every one of these episodes result in a shooting up of the blood pressure that even if it's not associated with low oxygen, can make you sleepy during the day because it's like somebody shook you hundreds of times a night out of your sleep. The other thing that happens is, and I just mentioned, these variations in blood pressure. I've seen people who've had blood pressure shoot up to over 200, hundreds of times during the night, and the next day and over the years they develop fixed hypertension. Cor pulmonale is a name for high pressures on the right side of the heart before the lung. So it puts stress on the right side of the heart, the right ventricle, and eventually leads to heart failure. So these things, you know, are not good. And it's chronic sympathetic nervous system activity that, as well as release of vasoactive substances and oxidative substances that actually damage the cardiac system and the neurologic system. Here's an example that, let's see if I can point this out here. Here's the, oh yeah, okay, so this is repetitive drops in the oxygen. You can see that. And they're due to repetitive blockage of the airway. And this is the blood pressure. Let me get that out of the way. So you see, every time there's one of these events, the blood pressure shoots up to 160 from 120, 160. Imagine that happening all night long. That's not a good deal. Let me move this forward. Wait a minute. Okay, so then you end up with a lot of chronic diseases. Hypertension, pulmonary hypertension, which is cor pulmonale, same thing. Heartbeat that is irregular, fast, slow, and most importantly is a condition called atrial fibrillation, where the top part of the heart is beating irregularly 300 times a minute. The reason we don't die immediately from that is because there's a blockage at the, what we call the AV node, that slows down. But so you'll have one beat that follows another beat very close, and then one that's further because the node doesn't let it get through. But the irregular heartbeat is associated with the atrium doing this, is associated with blood clots, which end up to cause strokes. So these folks are at high risk for that, and I'll show you in a couple minutes how that really relates to sleep apnea further. 1/3 of patients have, with sleep apnea, have high blood pressure, but 1/3 of high blood pressure patients have sleep apnea. So there's a connection. And a lot of them who have this have drug-resistant hypertension. 83%, in fact, of people with severe sleep apnea have drug-resistant hypertension. The definition of that is requires 3 or more drugs to control your blood pressure. There's a lot of people out there who have that, and that isn't a good thing. So you get, I won't dwell too much on this, but get slow heart beating, fast heart beating, and again, on the atrial fibrillation question, here's what I see is basically, and the literature supports this, there's a 50% reduction in recurrence of this irregular bad. It's a very prominent, or not prevalent disorder that causes a lot of stroke and has other comorbidities. And so if a person has sleep apnea and they're treated, the rate of this irregular heartbeat goes down by 50%. So it's worth knowing about. Here's the odds ratio of cardiovascular disease in patients with sleep disordered breathing. You can see on the left side here the odds ratio. Let me see if I can get that. How do I do it? Let me see. Anyway, not moving, so let me just put this back. Anyway, you can see on the left, 1, 2 means twice the odds ratio, 3, 4, and so on. And you can see mortality is up about 6 times higher with this disease. So even though it's just a disease that everyone kind of goes, oh, you know, he's got sleep apnea, it's a big time disorder. Coronary artery disease mortality is higher with this disease. The green is the frequency of myocardial infarction in 43 people who had significant sleep apnea. And the blue is 5 out of 16 who did not have sleep apnea. So mortality is high, six out of 16, I think I reversed that. 6 out of 16 who had mortality as compared to 4 out of 43 without sleep apnea. That's huge. Here's another interesting figure. So then you say, well, a lot of people snore, so what? But if you look at snoring and risk factors, let's look on the left. There are 36% morbidity in snorers compared to non-snorers. Well, actually, non-snorers without any risk factor, only 1 of 36 had morbidity and, died, and 3 out of 36 had some morbidity. But if you look at snorers with risk factors, 36 out of 36 had some morbidity, and 17 died. So it's, again, it's a highly significant abnormality. So if your spouse snores, you probably want to help them get evaluated, is really what I'm trying to say. Okay, so here's another, I won't spend time, but sudden death, higher than it should be with this disease. And they're in the handout. Then the other thing it does is fragment your sleep. So if you are asleep and you have this repetitive events that cause a brief, and we see it all the time with the electroencephalogram and body movement, we use a video. You'll see people with hundreds of these arousals, all of which are associated with blood pressure elevations. Then the next day, people are sleepy or they just don't feel right. And what does that do? The excessive sleepiness is associated with a lot of bad things. Vehicle crashes. I have people driving jet fuel trucks on the 10 freeway who had severe sleep apnea and were falling asleep. So you don't want to be next to one of those people. So, you know, it's a serious work issue, serious issue for the community as well. Sometimes we have to force the people who do commercial driving to remain off work until they resolve the problem. So here's, for example, the accident rates for these folks. I think the top is taking away my ability to see exactly what it says, but basically 29 people with sleep apnea, and there were 35 controls. The accident rate for the sleep apnea patients was almost 10 times, 8 times higher. And the accident rate at fault was, again, 8 times higher. And then, as you can see, at least one accident, 31% of people with sleep apnea had at least one accident. So that, you know, it's, again, to restate something. What else? It's subtle. This disease is subtle. I've had people say, I don't really feel bad during the day. And then when they get treated, they say, I didn't realize how impaired I was. But it affects thinking, skills, reaction times. Those have all been documented. And at work and at school, it really has an impact or potential impact on people. At the worst case, you can get elevated pressures in the brain. That's not exactly a common thing, but the scope of it is pretty important. Here's a slide that I just thought was interesting. It's IQ, which isn't always the best way to look at intellect, but you can see that sleep apnea patients had an IQ of 93 as compared to 100 for, this is relative, right? And then older people had lower IQs than younger, but young people with a high apnea index were worse than the normals at the same age. It's also a risk factor for stroke and sudden death. As I said before, the adjusted odds ratio for stroke and death are 2.24 and 1.97. That's a lot more people dying. I just had a poor lady who actually, her family member died in sleep and had sleep apnea. And the interesting thing about that is from a medical standpoint was that he was using a CPAP, then got up, went into the other room and fell asleep and died. So, you know, I just had that patient the other day. So here's another disease that's related to sleep apnea, diabetes. So you can see the insulin level, fasting plasma level of insulin goes up, the worse the breathing. Apnea, hypopnea index is the number of times each hour that the breathing partially or completely stops. So the impact is pretty big. How do you diagnose this? It's easy and hard, okay? So first thing is suspicion. These people are walking in not saying, most, I mean, they might not come to you that way. They come to me and say, somebody told me I might have sleep apnea. But in your clinics or in general, they don't walk in saying I have sleep apnea. They say I'm sleepy or I can't sleep well. So you have to have suspicion. Anyone who's overweight with sleepiness and hypertension or hypertension, that's somebody you should think about. In a kid, there's an interesting thing to know about. Children who are sleep deprived, I don't know how many of you have children, but what happens when your kid's really tired? Do they say, yeah, I'd like to go to bed and I'll go to sleep? No, they get up and run around more. They're hyperactive. A lot of kids who've been diagnosed with hyperactivity disorder actually have sleep apnea. The incidence is up to 4 or 5%, depends on the group. So a kid who's doing poorly in school, who may snore, who is thought to be hyperactive, needs to be evaluated for this. And I think dentists are often on the front lines with children too. I see kids like this all the time. So after you're suspicious, you get a history like that, and then we have a couple of questionnaires that help us identify. We used the Berlin questionnaire on 7,000 people coming in preoperatively in our hospital, and we screened them, and 35% were positive. But here's the problem. Of the 35% positive, very few got evaluated. They were told you're at high risk for sleep apnea, and they didn't follow up. So, anyway. So then we have methodologies to more formally evaluate that, because many studies have shown that even if you have clinical suspicion, it doesn't translate into positive or negative diagnoses. In order to diagnose this, you have to measure something about the breathing. And there are several ways to do that. And I'd like to talk to you about that for a minute. So we have a thing called polysomnography, which we do in our center. It means many something. I don't know what ography is, but poly means many, right? So there's a lot of leads. I'll show you in a minute. And we mostly do those as attended studies in the lab. And there's good and bad things. There is no one right way to make this diagnosis, but attended polysomnography is still the gold standard because, and I'll show you why in a minute, but some people do attended polysomnography in the home where they send a tech out and the tech is hooking up all these leads, which has not proven to be more cost effective either. And then we have limited channel studies, attended in the lab or unattended. And that's typically what we call portable studies. They've become more prominent recently because of the question of cost. So when you examine these people, you can look for these things, including in kids, large tonsils, and micrognathia, retrognathia. I won't tell the dentist what to look for in that, but I know you're very familiar with that. And leg swelling is edema in the leg, can be a hint in an older person. But none of them are perfect. So here's, I decided we'll quickly look at this. There are several levels of potential obstruction with this disease. The nasopharynx is the smallest area in the upper airway. And if you have adenoidal tissue, especially in a child, which is most what we see with this, you can have obstruction at that level. You can have obstruction for other reasons as well. And so that's one level. The oropharynx, it's usually the tongue and soft palate, and that relates to where people try to do surgery to remove the soft palate and so on. And that's in the handout too. And then in the larynx, anything that enlarges or interferes with normal motion of the epiglottis or vocal cord paralysis and so on can cause obstruction. Because this disease is a form of obstruction. It can be anatomic, or it could be physiologic, or a combination. The problem with trying to attack this disorder with surgery is that there could be multiple levels of obstruction. So, and the success rates for surgery have not been what we'd like them to be, I think because of that. Here's the hypopharynx, which, you can have large tonsils on the tongue and big tongues and things like that. So, but there's a classification that we use when we examine patients, but I think the value of it is relatively low. It's called Mallampati classification. It was actually an anesthesia kind of classification to find out who might be difficult to intubate. So you can see for yourself, if you ask somebody, stick your tongue way out, but don't say ah. Almost everyone says ah before you say that. You'll see, if you can see everything, it says 1, and you can see the progression. Also, tonsillar classification. You can see in the number, the last one, 4 has near midline tonsils. So what does that mean? Well, interestingly, in children, there hasn't been a great correlation between the size of the tonsil and the severity of the sleep apnea. So, but it's something you can note. Here's one of our polysomnograms that we did recently, one of our patients. And here's, this one I really want to be able to move the mouse. Mike, I don't know, doesn't want to move for me. Am I moving a mouse? No. Oh, there it is. Okay. So basically what you're seeing here is see the red bars, for some reason that keeps popping up. This is normal breathing in here. Here's another example of normal breathing. I just went back. So then all of a sudden the breathing stops here. This is up here is the electroencephalogram. We won't pay attention to that, but this is the breathing. And you see how it starts really big and then gets lower. It's a partial obstruction and a certain pattern. But you can see that when that happens, the oxygen drops. And this guy had severe sleep apnea, and he was not functioning well, and the oxygen went down. Anything below 90 is really potentially dangerous. I don't know how many of you are familiar with the oxyhemoglobin dissociation curve. When you get below 90%, a small change in the PO2 will drop you right down to a very low saturation. So that's him. And here's an example of, this one is not ours, but it's an example of the heart rate response to this. See here, there's no airflow going on in here. See how the heart rate is slow, became very slow. And then at the end of the event, there's a recovery breath. And after that, there's a very fast heartbeat. So you get this cycle of slow and fast heart beating, which is not good because it's sympathetic and vagal nerve related. So Okay, now, unattended portable studies are being used. The American Academy of Sleep Medicine's recommendation for this is the patient should have severe clinical problems and unable to be studied in the sleep lab or to evaluate a follow-up. Let me show you the next slide. Here's why. So if you look at this study, I won't spend a lot of time on it, but basically these are breasts that are partially flattened, but here it really flattens, and the person has a partial obstruction that's causing sympathetic tone to go up and blood pressure to go up, and an arousal, which occurs right in here through the, see, right in, somewhere in here. So that's never measured with a portable. I'll tell you a patient I just had. This was someone who was on CPAP for years. They changed insurance. They came to me and said, you know, I'm on this CPAP and the new insurance company wants me to validate it before I can get a machine, right? I said, okay, just take a portable home and we'll try to make it easier for you because I know you were severe. She gave me a report of a severe sleep apnea. I did it. Guess what? The portable was negative, entirely negative. I said, come into the lab and we'll check. She was severe. Now, why else could a portable be negative? It could be negative because the patient never slept. You're going to get a negative study. You're not measuring sleep. So for that reason, I would caution, not that it definitely has a place, but you have to be aware of all these things that could give. So, and there's a 20% false negative with portables. Let me move on. Okay, so I'm not going to spend a lot of time, but there are several ways to treat this. Dental stuff is listed under medical treatment. Behavioral treatment's kind of, you know, lose some weight, try to sleep more on your side. You can elevate the bed, quit smoking, do all the good things in life that you can do. Success is relatively low. I'm not going to spend any time on that, but weight loss does help. This is the apnea index related to body weight. You can see it goes down the thinner you are. So it's not a great study, but anyway, medical treatment. Oral appliances is listed as number 8. I would put oral appliances up much higher because I think they can be very effective for the right people. And we have, we're fortunate a dentist colleague of mine is seeing patients in our center now and makes the appliance. And we use what's called a matrix study. I don't know how many are familiar, but basically it's a titratable device that we can actually measure. So the dentist tells us how far forward protrusion with a mandibular advancement device that the that the chin can be moved forward, which opens the airway. And within those parameters, we titrate all night until it's controlled, till the sleep app's controlled. And we find that very useful because if not, then the patient goes through a whole sequence and gets the dental device, and then they come in and we test them, and you know they don't necessarily feel better, and the study is positive. So we're moving toward documenting the effectiveness of the device and titrating it with the dentist's cooperation. We don't tell the dentist how far to move the device, or you know, we just follow whatever they say and we titrate. Okay, here's a list of surgical treatments. How many of you, what do you think when you see these surgical treatments? What does it mean to you? To me, it means nothing works well, because there wouldn't be all these surgeries. We've kind of abandoned all of the uvula palatoplasties. They don't work well enough for the wrist. I think what we've come to, and maybe, you know, future things will change it, but right now, maxillomandibular advancement, we've had seeing success in some patients, particular retrognathic people, but there's a new surgery which involves implanting an electrode on the hypoglossal nerve. and it's stimulated every time you take a breath. And that published studies in the New England Journal support that. We've sent 4 people so far, and they all, I think, had a pretty good response and are happy about it. But that's cost $40,000, and insurers are not necessarily paying for it yet. So anyway, that's where that is. Now, CPAP. The argument against CPAP is compliance, and there's no question. The biggest problem with CPAP is putting something on your face and the interface, to use something like that every day, particularly if you're young and face using it for a long time. So, but compliance, in my view, relates to 2 things. The degree of sleepiness, or how bad you feel before, and the place you go to get the CPAP. Because many people are tested, given a CPAP device, and they can't use it, and they never see a doctor again, and they just put it in the closet. I had 2 this week like that. In our situation, we spend a lot of energy with people to, they may have to try 3 or 4 masks before they get the right one. So with that, I would say you can expect 70 to 80% compliance over time. I just had a guy this week who told me, my life changed. You told me it would be good. I tried it. I hated it. Kept changing stuff, and now I can't sleep without it. So it's like anything. It's not meant for everybody, but, it's like anything. You have to give good care related to it. So here's a CPAP, and basically it just opens the airway. Doesn't care where the obstruction is, so it's kind of a dumb approach, but it's safe, and it works. Here's the same guy after CPAP. Remember I showed the guy with all the blockages? This is in our center. And notice that the breathing, this is the breathing up here. Whoop, why does that do that? Probably because of what I'm doing. Wait a minute. How do I get back now? Oh, there. Okay, so this is now the breathing, right? Pressure's at 7. And look at the oxygen. Can you see that? It's not going up and down. It's down at the bottom here. See, it's stable. So that, anyway. Blood pressure improves after CPAP. Sleepiness gets better. Quality of life, there's SF-36 scales. And you can see that the quality of life for a sleep apnea patient is approaching normal, the general population being normal. One thing that bothers me about this graph is the general population seems to be getting worse as you look at it. So anyway, here's atherosclerosis after CPAP. So they did that with intimal thickening using ultrasound. Okay, so there's definite benefit. Long-term compliance, this shows a somewhat higher compliance rate than most people have reported. I'd say 70 to 80% in the right places. Some places have 30%. So, okay, here's the oral appliance information, which personally I think is highly important, and as is dental surgery. I won't go into it because there are people here far more expert. Just say that we have become convinced, and the literature supports the use of this for mild to moderate sleep apnea, or for more severe people who can't tolerate CPAP. And the thing about that is that we shouldn't be stuck in saying, well, we won't do that. That's something we don't use. No, it works. So we should be very, very much together working with our colleagues. So in conclusion, it's a common undiagnosed disorder, results in multiple other serious disorders. It's diagnosable, it's treatable, and dentists have a significant role to play in this, identifying the disorder and treating it. So I thank you very much for the opportunity to be here today talking with you. Thank you, my pleasure. Yeah.
Thank you very much, Dr. Nicholson. That was excellent.
Thank you.
We do have a few minutes for questions. Does anybody care to throw a question out there? Someone here?
Yeah.
Really helpful is when they have a PSG, it states that it will benefit, but not every lab does that, so it makes it really difficult because then if medical won't pay for it, patients usually don't have the funds, so then they remain non-compliant or they're not treated.
Do you want me to take the mic? Or I haven't, yeah. Oh, that's a really good question because it's practical. So we report out that we recommend dental device with this, and we send the order, we sign an order, please evaluate this person for treatment with mandibular advancement device. And we don't tell the dentist what to do, we just say, please evaluate. And we, you know, you have to kind of get colleagues who will work with you on that. And so I think it's a good point. You can't just treat somebody without some support.
Yeah, because potentially the non-compliance with CPAP also is related to how high the pressure is going used by the CPAP or both the airway. So we could also work together in combo therapy, like you suggested, with the sleep appliance that we can make with the advancement, and then perhaps the pressure would also drop the patient, might get more compliance.
I can't disagree. We should work together, and there is no one perfect treatment for this. Sometimes combo treatments are the best thing. So I agree, and I applaud your thinking about working in that way. So, you know, let us know how we can help too. So.
Okay, any other questions? There's a question over here. Oh, great. Thanks, Michael.
Thanks.
Just a quick question about the equipment. If they
Oh,
are
that's
one
a
of those
question.
people, no, it's me. If there's somebody that has equipment and hasn't used the machine,
Yes.
how long is it going to be compatible with new masks?
How long? So the question is, if you get a machine and you don't use it, let's say 5 years goes by, and how long, is that the question? Well, if a mask is 5 years old, it's not going to work, no matter if it's just sitting in a closet. So you need a new mask, but the machine will still be compatible. Yeah, you can get multiple.
I just wanted to relate personal experience. I was diagnosed quite a while back with sleep apnea, mild, and tried a CPAP machine at the time when it was like the full face mask.
Yes.
And just found it to be impossible. So I put it in the closet and didn't use it.
Yeah.
And then more recently did another sleep study and still had the mild sleep apnea. I was experiencing a lot of problems with sleepiness. And so I wanted to do the dental device. And I kind of downplayed the problems I had had over the years with my TMJ. So, because I really wanted the dental device, because I didn't want to do the machine again. And when I tried the dental device, it really made the pain in my jaw very bad.
Yeah.
So then I did get another CPAP machine, but now the masks had changed. And so I've had a great experience with it and used it now for about 3 years.
So the technology, what you're saying is the technology has improved, the masks have improved, and you know, we have 30 different masks that can be used. Some of them are this big and they go over here and so on. So, but it's like anything, you have to have somebody who's working with you to get you what you need. Milder cases are more difficult to treat. I agree. Thank you. That's a good point. I see there's a question over here that I ignored, not out of ignoring, but out of not understanding where it was coming from. The question was, I noticed that the Epworth Sleepiness Scale has not been mentioned. Is this questionnaire no longer reliable? I didn't mention, so I apologize for that. It's a standard. We use that. It's been validated several times, and we use it for sleepiness, not as a scale to determine severity, likelihood of sleep apnea. But if somebody comes in who's hypertensive and has a very high score on the Epworth sleepiness scale and they snore, putting those together, that would be bad. We also use the Epworth sleepiness scale as an index to follow, but also to say you better not drive while you're, sleepy like this. So it's a good scale.
Any other questions? I see a hand up in the back.
Thank you, Dr. Nicholson, for
Sure.
a great presentation.
Thank you.
My question is, I assume that a patient who's suffering from sleep apnea, as long as they are awake and they are lying down, they're not going to have any problems. So my thought was that, is there possibly a disconnect or any effect between the reticular formation, basal ganglia, motor, before even we get to the treatment? Could it be a neurological effect as well, that keeping the tone, keeping the connections to the respiratory centers? And if there have been any studies looking at the circuitry that is kind of kicked out, dismantled while we are sleeping, so that tone and that activity is inhibited and doesn't work, so that we can get the consequences of apnea and not having enough oxygen and the effect on the rest of the body. Thank you.
Well, thank you. That's a really good question. And there clearly is a neurological component to this disorder. People have tried drugs, for example, that suppress REM sleep. Years ago, we used to use a drug called protriptyline to suppress REM sleep. And it had some effect, but it was too toxic to take long term. The people have worked on this at the end point of that, which is the upper airway stimulator that stimulates the muscle tone in the airway. In that case, what they're doing is saying, yeah, it's a neurological problem, but we can't get to the brain very well, so we're going to do the endpoint and use a neurostimulator. So absolutely, if we could get to where the exact locus and loci of these neurological manifestations, it could be treated. But also, the problem with this disorder, it's a combination of anatomy. For example, if you take somebody with severe retrognathia, and they even have mild neurological abnormality, their airway is going to block off because there's no airway to begin with of any size. So that's what's made it so difficult. It's the combo, but you're right on the right track. There needs to be more research on it too. Yes, sir.
My question is, has there been a relationship between cervical extension, the loss of cervical extension, especially as you grow older, and the onset of sleep apnea?
Well, that's a really good question. I'm not deeply familiar with it, but I can tell you from anesthesia, my anesthesia experience, people who can't hyperextend the neck, have arthritis, have a high incidence of airway obstruction as soon as you put them to sleep with anesthesia. And so it's highly possible that even a thin person, and sleep apnea does get worse as you get older anyway. So I'd be interested in looking at that research and seeing if there is a direct connection that way. Thanks. Yes? Oh.
Question?
My husband has a history of snoring pretty badly, and he went for sleep apnea lab testing overnight, and they found out that he did not have sleep apnea. And he still snores, and I was wondering, would you recommend a second test again? Could somebody convert from not having it to having it, considering that the weight stayed the same and there's no systemic conditions?
That's a great question too. The question is, if you have one negative test, should you get a second if you're highly suspicious? Let me sort of frame that, because I have seen negative tests because the person slept on their side all night during that first test. I had a guy recently who came in and had only very mild sleep apnea. I said, you know, you had very mild sleep apnea, but you only slept on your side. He said, that's because I can't sleep on my back, I can't breathe. Okay? You know, so what I would do with a person like that is to get more of the history. How do you sleep? What's this? Let me see the study from before. Let me see what the position was, and so on. Did you have an alcoholic drink most nights and then you didn't that night? There's all kinds of variables. Have you lost weight? Have you, so yeah, I mean, I don't think I'd be satisfied with one negative study unless I looked at the study and talked to the patient. Yeah.
We have one last question, and we do have another class coming in starting at the top of the hour here. So if it's a quick one, that'd be welcome. Yeah, thank you.
Hello. So I was a sleep technician before I started school, and they didn't really promote too much oral appliance type use. Because you were saying for mild and moderate sleep apnea, like an AHI below 15, will you start looking into oral appliances? Or are you exploring it for over 15 events per hour? What's kind of like the criteria now?
So the question is, what's mild or moderate? Is that what I'm hearing? Yeah. I mean, what category of severity by what criteria? Correct? Yes? Or am I not saying it right?
When do you promote an oral appliance, 15 and below, or do you promote for any patient if they really can't stand?
Well, okay, it's more complex than that. The question is, when do you apply that logic to using an oral appliance, right? So there's several factors. Patient preference, right? So somebody says, I'll never wear a CPAP. If they're 25 or 30, I might use it. Oral mandibular advancement device. Or somebody who is more severe and has not tried, can't tolerate CPAP. Now, on the other end of the spectrum is clearly, the definition of American Academy is less than 15 an hour. And that would make it a mild case. However, even that's open to question. It depends on how your lab scores this stuff too, because you can be way off base on, and anybody wants to talk to me about that, I'm happy to do it. You have to really know how the people you're doing the study, what they're telling you. What is it? Thanks.
Thank you, everyone, very much. Thank you, Dr. Nicholson.
My pleasure. It's nice to come, a very good group.
Thank you. It was very
Maybe we can get together.